start already time ആയിട്ടുണ്ട്.
Oh yes.
Good evening to all. The respected chief guest, Professor Sekharan sir, our senior faculty, Professor Madhusoodanan sir, Professor Sreedevi madam, dear delegates who are attending the meeting. Our secretary, Dr. Wahab, will be joining soon. And with regard to Perindalmanna ONG Society, this is our third e-crosstalk. Anyway, now everything is in the e-format. So the crosstalk actually we have planned because there are not much interactions happening between our specialty and the concerned other specialties which are related to common obstetric practice. So, so far, because the webinar has already become a pandemic, many of the topics have already been discussed in multiple number of times. But we cannot see very often the neurological disorders have been discussed in detail. So this time we have carefully selected this topic, and we got a very wonderful faculty to discuss this problem, neurological diseases, complicated by pregnancy. So I would like to introduce the chief guest and all the faculty by a short presentation. I'm just sharing my presentation now. So our chief guest is none other than our beloved Professor Sekharan sir. Sir is inaugurate this program. And sir is presently the senior gynecologist and head of the Department of Obstetrics and Gynecology at PVS Hospital, Calicut. And sir has served as the National Vice President of FOGS, and he was the past president of KFOG and one of the major pillar who has created and stitched KFOG into this current shape. And former professor and head of the Department of Obstetrics and Gynecology at Government Medical College, Calicut. And he has served for lot many years as the specialist in Indian Army, and has been invited faculty to many national and international conferences. Organizing conferences and speaking at conferences, sir is one of the most important weaknesses which we have all noted. And there are a lot of publications to his credit in index journals, and sir has a specific interest in the research in gestational trophoblastic disease, and he has organized the first ever World Congress of Gestational Trophoblastic Disease for the first time in India. And our next faculty is Professor M. Madhusoodanan sir. And I got connected to sir through Sreedevi madam, and sir has readily agreed to participate in this meeting. And sir is currently the professor and head of the Department of Neurology, Travancore Medicity Medical College and Hospital at Kollam, and adjunct professor of neurology at Manipal University Hospital, and senior consultant neurologist at PRS Hospital, Trivandrum, Professor Emeritus Medical College, Trivandrum, former professor and head of the Department of Neurology at Medical College, Kottayam, and has 36 publications in national and international journals, and contributed 15 chapters in textbooks of neurology and medicine, published a book on higher neural functions, winner of the Epen Samuel Award for the best research paper in 1998, awarded the Lifetime Achievement Award by the New Controversies to Consensus in Neurology in the year 2014, and awarded the Master Teacher Award by the Shine 2015 at Chennai, and awarded the Lifetime Achievement Award from the Neurological Society of India on February 2020. I used to listen some of his case discussion series as webinars quite often, and very much impressed the simplest way he used to present the topic and communicate to the juniors like us. And madam, the Professor N.S. Sreedevi madam, she is currently the professor and head of the Department of ONG at Pushpagiri Medical College, Thiruvalla, former professor and head of the Department of OB/GYN at Government Medical College, Calicut and Kochi, past president of KFOG and assessor at CRMD, that is Confidential Review of Maternal Death Series, and contributed chapters in Why Mothers Die, a popular the practical textbook in the gynecologists in Kerala and in India all across, and invited faculty to many national and international conferences, and she has a lot of publications to her credit in the indexed journals. So with this few words, I would like to invite our beloved Professor P.K. Sekharan sir, fondly called as PKS, for all his, actually all the gynecologists in Kerala are his students some way or other. Even though I have not studied in Calicut Medical College, I had the fortune to learn a lot from sir's classes and lectures very often. So with this few words, I humbly invite Professor P.K. Sekharan sir to inaugurate this today's Crosstalk and moderate the entire proceedings to make expert comments following the presentations. Over to you, sir.
Thank you. Respected President of the Perindalmanna Obstetrician Gynecology Society, Dr. Kunyumoideen, Secretary Dr. Wahab, respected members of the society, dear delegates. First of all, let me thank Dr. Kunyumoideen and the team for this kind invitation. Now, Perindalmanna Society is actually the youngest in our federation, both in Kerala as well as in all India level, maybe 1 year plus in their existence. But they have made a mark, not only in Kerala, but all over India. And Foxy also has appreciated their effort of conducting so many webinars and scientific meetings. And Kerala also, we are enjoying their contribution to science. Not only in the difficult period of COVID and when we were all rather depressed, the cultural program arranged by the society is also wonderful. And Kunyumoideen is one of the very good actors I have seen. As I can still remember the Musiliar or Tangal and also the Chakir recently through Kunyumoideen and his assistant also, very good. So that is apart. They have contributed both way in our difficult time, both in scientific as well as in cultural field. Now, this topic of neurological problems in pregnancy, luckily we are not having much frequent problem facing, but world over, almost 5 to 7% of the deaths are due to neurological problems in mothers. So that is how the importance comes. The major problem that we may have in neurological problem is epilepsy. A pregnant woman with epilepsy or woman with epilepsy becoming pregnant and look after the pregnancy is not at all easy. The medications and the dose and adjustment and other things. And next, I could think of a neurological problem is associated with hypertensive disorders pregnancy, especially problems like press and other things, which will be made aware of this thing. We are happy to see a very eminent faculty to cover this topic, Dr. Professor Madhusoodanan, who will cover the neurologist point of view and make us know all those complications, and also to put forward our views and problems by Professor N. Sreedevi. We were working together at Calicut quite some time, and she is also associated with the research in gestational trophoblastic disease, and she had also attended many conferences abroad. And so we are having two very eminent faculty to cover the topic. Let us listen to them, and we'll then finally go for the discussions after the presentation. Thank you, Kunyumoideen, once again. Thank you, the faculties, for attending this, coming for this meeting. Thanks, the delegates who have joined.
Thank you, sir. Now I invite Professor Madhusoodanan, sir, for his presentation on neurological issues in which can happen in pregnancy, as well as its current guidelines and opinions. Over to you, sir. Unmute him, sir. Unmute him.
Yeah, am I audible to you now?
Yeah, yes, sir.
Yeah. Can you see my slides now?
Yes, sir.
Okay. At the outset, I would like to thank Dr. Kunyumoideen and Dr. Sreedevi for inviting me to be a part of your program. Now, as introduced by the chairperson, the topic I'm going to cover is the neurological disorders complicating pregnancy. Now, as the chair has already told you, I'm going not to discuss all the complications, but concentrate on mainly three aspects. One is epilepsy and pregnancy. Second is in a pregnant woman coming with acute onset of headache. And third is the stroke, which can also occur in pregnancy. Let us come to the first topic of pregnancy and epilepsy. There are two case scenarios by which a patient can come to you with this problem. First scenario is a 24-year-old woman who is in a non-epileptic on anti-epileptic drugs, has come to you with pregnancy of 2 months. And she has these following questions to you. Sir, I am taking these medicines. Will it be harmful to my child? Will these medications affect my pregnancy? What if I stop the medications? Can I reduce the medication dose? Do I have to change the dose of anti-epileptic drug during pregnancy? Suppose if I continue to take these medicines, will my child develop subnormal intelligence or any other behavioral problem later on in the child's life? That is one case scenario. The other scenario is a 20-year-old woman who is a non-epileptic on treatment, got married and want to become pregnant, preconceptual counseling. She wants to know the following questions. If I become pregnant, will my epileptic attacks increase? Will the medications to be harmful to the child? Same question that the previous in the previous case scenario. She may ask, if I stop the medicines now, my child will not be exposed to the drugs. If I develop seizure attacks in that bargain, is it not better than the side effects of the drugs so that I can save the child of my side effects? Can I change to less harmful medication? And can I reduce the dose of the drugs? So these are the questions I am going to address in the first part of my talk. Let's come to the first case scenario. A woman has already become pregnant and comes to you for counseling. So the first question is, I am taking these medicines, anti-epileptic drugs. Will it be harmful to my child? The most women with epilepsy give birth to healthy offspring. However, children of women taking AEDs, AED means anti-epileptic drugs, during pregnancy may be at increased risk of birth defects, premature birth, low birth weight, and low ABCA scores. The overall frequency of the major congenital malformation is 3 times greater in children of women with epilepsy than without epilepsy. Even normal women, but remember that even normal women without any medications are not free from developing any malformation in their children or fetus. The risk is to the tune of 2.2%. If the person is on multiple drugs, more than one drug, the chance of developing fatal malformation is higher. It is about 6.8% versus 4% with monotherapy. And the risk is dose dependent. Higher the dose of medication, the higher the rate of malformation. For example, in the case of sodium valproate, which is a very good drug for generalized chronic seizure, if the dose is more than 700 milligrams per day, the risk of developing malformation is higher. The cutoff for carbamazepine is 400 milligrams. For phenobarbital, it is 150 milligrams, and amortagine is more than 300 milligrams. So higher the dose, higher the risk. Now, what are the anti-epileptic drugs identified as a major malformation risk? From highest to the lower level of risk, which are the ones which more risk compared to the lower ones. Valproate has got the highest risk, that is 8.9%. Phenobarbital is the next in line, 6%. Topiramate, 5%. Carbamazepine, 3%. Phenytoin, 2.8%, nearly 3%. Lamotrigine is 2.1%, and levetiracetam is 2%. Already told that even normal women can have a risk of over 2%. So that tells you that levetiracetam and lamotrigine did not significantly increase the risk of major congenital malformation. So they are the safest medication as far as the drug is concerned for the epilepsy during pregnancy. Now, next question is, what are the major congenital malformations child can have? They can have neural tube defects, cardiac malformations, facial clubs, hypospadias, and brain malformation. And I mean, the risk of valproate is significantly higher than the other antiepileptics already told. Moreover, valproate exposure in utero is associated with an increased risk of autism and autism spectrum disorder. And the risk is dose dependent. Daily doses of more than 1,500 milligram per day is associated with the risk of 24%, whereas doses of 700 milligram per day less is carried separate 6%. So always we want the person want and valproate to be continued. It is ideal to keep it below 600 or below 700. The next question they can ask you is that, okay, will this medicine supplement pregnancy other than the major malformations? Women taking AEDs are at higher risk of developing prematurely, that is delivering prematurely, that is less than 37 weeks, and giving birth to a small for gestational age newborn. There is a higher risk of preeclampsia, preterm labor, increased cesarean delivery, and prolonged hospital stay, as well as tenfold increase the risk of mortality in persons who take antiepileptic drugs. The other question they can ask is, will we have a problem during my delivery? Women with epilepsy are at risk of adverse delivery outcomes, including peripartum infection, placental abruption, induction, elective cesarean section. Seizures during delivery can occur in 2% of women with epilepsy, with a greater risk to those who have subtherapeutic AED levels. Maternal seizures in labor may result in prolonged uterine contractions with slowing of the fetal heart rate. Now, the next question they can ask is that since these medicines are harmful, can I stop them or at least reduce the dosage? Many of them, you may be remembering that may have already reduced that drug or they stopped it and then come to you. There is no meaning in stopping or reducing the medicines now. Since the organogenesis occurs in the first 3 to 8 weeks, the drug has caused any side effect, it might have already been caused. So there is no point in stopping the anticonvulsants at this point of time. Moreover, by reducing the AED dose, you are likely to develop recurrent seizures, which is actually more harmful. The next question is, do I have to change the dose of antiepileptic drugs during pregnancy? The most common cause of seizure recurrence during pregnancy is reduced plasma concentration and change in the drug metabolism. The plasma concentration fluctuates during pregnancy because of several physiological reasons, including increased renal clearance, altered hepatic absorption, increased plasma volume distribution, hepatic enzyme induction by the steroid hormones during pregnancy. However, dose modification is not required for all AEDs during pregnancy. Most you can continue without any drug modification, except probably 3. One is a lamotrigine, where you have to increase the drug dosage, especially in the second and third trimester. And oscarbazepine, which also has to be increased by about 50%. And levetiracetam also dose modification has to be done. So these drugs, persons who are on these drugs require a blood level estimation of the drug for modification during pregnancy, comparing with the pre-pregnant level of the blood level of the drugs. The next question they can ask you is that, do I have to change the dose of antiepileptic drug during pregnancy? The same thing question. The American Academy Practice Guidelines suggest that checking antiepileptic drugs at baseline before conception and monthly thereafter. Dose adjustment should be considered to maintain an effective and stable level throughout pregnancy, at least for women with epilepsy who are taking lamotrigine, oscarbazepine, levetiracetam. The other question is, if they continue to take the medicines, will my child develop subnormal intelligence or any other behavioral problems? Fetal valproic acid exposure is associated with lower IQ and reduced cognitive abilities in a dose-dependent manner. Exposure to other AEDs, including carbamazepine, lamotrigine, phenytoin, etc., is not associated with lower IQ in children. The periconceptual folate supplementation has a positive association with a better neurodevelopmental outcome, a lower rate of autism spectrum disorder in general population, and higher IQ in children exposed to AED in utero. So this is a must in persons, especially in taking antiepileptic drugs. Another question they can ask you is that, okay, I delivered now, can I breastfeed my child after delivery? There are, as you all know, there are many advantages of breastfeeding because the reduced risk of lower respiratory tract infections, atopic dermatitis, asthma, otitis media, gastroenteritis, diabetes, childhood leukemia, all and much less in persons who are breastfed. And breastfeeding is also beneficial to the mother in reducing the risk of breast cancer, ovarian cancer, postpartum depression, and diabetes mellitus. So all AADs can be transmitted into the breast milk to some degree, but this amount is much less than the previously transmitted from the placenta to the fetus. The actual infant AAD exposure from breast milk is usually low, and benefits of breastfeeding outweigh the potential risk for the newborns. So breastfed children, moreover, breastfed children exposed to AADs in utero are found to have higher IQ and enhanced verbal abilities compared to children exposed to AAD in utero who are not breastfed. So always breastfeeding should be encouraged in persons should you are talking on antiepileptic drug. Is there any particular drug which is actually more in the breast milk which can affect my child? In those who are on barbiturate and benzodiazepines, which are hardly we use now as antiepileptic drugs, these are which can cause reports of sedation lethargy. So except for these drugs, the reported side effects in infants who are breastfed on other AADs have been rare or infrequent, and benefit definitely outweigh the risk. So the answer, straight away answer is you can definitely breastfeed these children. Now come the second scenario. A 20-year-old woman is non-epileptic on treatment, got married, has not become pregnant now, but wants to become pregnant now. Now, the question she is going to ask is, will I have trouble in getting pregnancy? Reassure the patient that fertility is the same as in general population in women with epilepsy. They can become pregnant, let's say, same, the risk chance is same as any other individual. If I become pregnant, will my epileptic attacks increase? The majority of the women with epilepsy, pregnancy has no effect on the seizure frequency. Therefore, if seizures are well controlled, they are likely to remain so during pregnancy. However, in approximately 20 to 35% of pregnancies in women with epilepsy, an increased seizure frequency occurs during pregnancy because of the change in the blood level of the drug, which already been mentioned, especially on lamotrigine, levetiracetam, and oscarbazepine. Generally speaking, if the patient is seizure free 1 year before pregnancy, it is very unlikely that she will continue to remain. It is very likely that she will continue to remain seizure free during pregnancy in 80% of instances. Will the medications be harmful? This has already been answered earlier, but they can ask this way. See, you said that medications can be harmful. In that case, if I stop the medications now, my child will not be exposed to the drugs because I have not started any medication now. I may not become pregnant now. If I develop seizure attacks during pregnancy, is it not a better option than the side effects of the side effects of drugs for my child? For that, you must know the risk to the fetus because of the maternal seizure recurrence. Women with epilepsy experience seizure during pregnancy are at increased risk of delivering preterm, low birth weight, and small for gestational age newborns. Moreover, frequent maternal and tonic-clonic seizures during pregnancy are associated with lower verbal IQ in the offspring. The benefits of using AED during pregnancy may outweigh the potential teratogenic side effects. How do the recurrent seizures affect the fetus? The seizure-related risk may be related to fetal hypoxia, acidosis, decreased blood flow to the placenta, deceleration of the fetal heart rate, and trauma as a result of the maternal fall during the GTC seizure. The other scenario is that the seizure is coming. This is not a question from the woman. Person does do you know a seizure during the first time during pregnancy? It was not a non-epileptic patient. If that is a situation, consider the first secondary causes or symptomatic causes first before considering idiopathic seizures occurring for the first time. And these are the causes like venous thrombosis, breast, hypertension, encephalopathy, eclampsia, and there are certain tumors which can grow during pregnancy and bleed from AVM should be considered to be ruled out before branding it as an idiopathic seizure. Now coming to the second scenario is a person who is pregnant, developing an acute onset of headache and comes to you. Now, if that is a situation, find out whether this headache is occurring for the first time or there is a past history of headache. If there is a past history of recurrent headaches, ask whether this headache is similar to the one which the patient had earlier. If the answer is yes, one can safely think of a benign condition like migraine need not warrant further investigation doing unnecessary MRI or a CT scan. On the other hand, the patient says that this is the first time the patient had this type of headache. Always rule out secondary causes of the headache first. Check for hypertension or any evidence of preeclampsia and HELLP syndrome. Ask and look for neurological dysfunction, especially blindness, focal weakness, paresthesia, and papilledema. Ask if the headache is precipitated by straining, especially, for example, straining at stool or precipitated by violent cough, etc. The patient is in the vulnerable period for developing preeclampsia and HELLP syndrome after 20 weeks or up to 3 months postpartum. Then preeclampsia should be the first consideration patient coming with a headache. If preeclampsia and HELLP syndrome is ruled out by the available investigation, which you know better than me, then consider the following possibilities. PRES syndrome, as Chairman was talking about. RCVS, I'll tell you what RCVS is. CVT, subarachnoid sinus thrombosis, subarachnoid hemorrhage, dissection, and pituitary apoplexy. Now let's see this case. A 24-year-old female who is 36 weeks pregnant, comes with headache and vomiting for the last 3 days and 1 episode of focal seizure. Sinus examination is normal. So what are the conditions you have to keep in this scenario? There are 3 major possibilities you have to keep. One is a PRES syndrome, second is venous sinus thrombosis, and RCVS. And the differentiation is difficult by clinical examination history-wise, and you may have to resort to investigations. Now, what is PRES syndrome? Then you must know what is PRES, what is CVT, what is RCVS. Now, PRES syndrome, in PRES syndrome, patients typically present headache, visual symptoms referable to the occipital lobe, like visual occipital hallucinations or blindness, and seizures. The usual precipitating factor is sudden increase in the blood pressure. But BP need not be necessarily high all the time. There is an overlap between PRES and severe preeclampsia and eclampsia, and the disease may be complicated by several hemorrhages and ischemic strokes. And the radiological features of PRES can exactly mimic eclampsia in nearly 98% of the instances. So whether it is preeclampsia type of PRES, one cannot certainly can argue about it, we don't know about it. It is possible. The severity of the clinical symptoms varies in PRES syndrome. The visual disturbance can manifest as blurred vision, homonymous hemianopia, or even cortical blindness. Patient can be mildly confused or agitated, but can become comatose. Other symptoms less commonly seen include nausea, vomiting, and brainstem deficits. Seizures and status of epilepticus are also known. Now, what causes PRES syndrome? Its most common cause is hypertension itself. Other causes include chronic kidney disease, autoimmune disease like SLE and TTP, and exposure to drugs like cyclosporine, tacrolimus, and chemotherapeutic agents. This is the MRI picture of PRES syndrome, which you can find the findings are predominantly right occipital, but that need not be the case. It can be in the frontal subcortical, it can be in the basal ganglia region, it can be in the thalamus, even in the posterior findings can occur in PRES syndrome. Now, the other condition we can come to DD is cerebral venous sinus thrombosis, which you all know, which can people are more likely to develop when women are born during the pregnant or postpartum period. They present with either features of increased lateral tension, or only seizures, or focal deficits due to infarction hemorrhage, or a combination of all the 3. So they may present only one symptom or all the 3 symptoms. The risk of CVT is more during late pregnancy and even more so during puerperium. And hemorrhagic infarction can occur in acute stage of CVT. The most common present symptoms is headache is the most common, then seizures next common 40%, and papilledema. Other things which can occur are the visual loss, diplopia, fluctuating motor and sensory deficits, stupor, and coma. This is the MRI, CT and MRI showing a hemorrhagic infarct here. This is the sinus venogram showing the occlusion of the lateral and sigmoid sinus. How do you treat? And you have to treat with anticoagulation. Even if the patient's got hemorrhagic stroke, hemorrhage in the brain, the drug of choice is the drug to be given is anticoagulation. During pregnancy, the low molecular weight heparin subcutaneously is preferred. Avoid warfarin. For women with history of cerebral venous thrombosis, pregnancy is not contraindicated as long as prophylactic low molecular weight heparin is administered during pregnancy. The third situation which can come with you with severe headache and seizure is reversible cerebral vascular. Without seizure is reversible cerebral vasoconstriction syndrome, otherwise called as RCVS. These are disorders characterized with long but reversible vasoconstriction cerebral arteries, associated with acute onset severe recurrent headache with or without additional neurological signs and symptoms. The hallmark symptom is the recurrent thunderclap headache. Thunderclap means sudden severe headache. There are very many synonyms like benign angiopathy or CVNS, postpartum angiopathy, cord-fleming syndrome. So many terms for this condition, but this is the favored one. That's already told the hallmark symptom is a recurrent thunderclap headache. They can have neurological signs and symptoms in the form of transient or permanent visual deficits, in the form of hemiplegia, dysarthria, whatever is focal neurological deficits. And the deficits can be due to ischemia or due to ischemia second due to vasoconstriction. The causes can be many. The most important cause still is the pregnancy and puerperium. It can occur during in puerperium, late pregnancy. It can also occur during eclampsia and preeclampsia and delayed postpartum eclampsia. Other is exposure to various drugs can cause, especially sympathomimetic drugs like phenopropanololamine, a drug which is present in your cough syrup, pseudoephedrine, and antimigrainists like ergotamine, and SSRIs like fluoxetine. Other conditions, there are many drugs like somatriptan, tractarilisectin, that are less common drugs, less commonly used. There are also other miscellaneous conditions that can cause RCVS like hypercalcemia, pheochromocytoma, carcinoid tumor, and endarterectomy, etc. And the most common is still idiopathic, where there is no identifying speed factor, but they usually give one complaint. This developed for the first time during staining or during defecation or during violent cough and all that, they precipitate this condition. How to diagnose? By the CT angiography or MR angiography, which will show multifocal segmental arteries and artery vasoconstriction. There is no evidence of aneurysmal subrectal hemorrhage. CSF is normal. The characteristic thing is that this vasoconstriction reverses itself within 12 weeks after the onset. You can see the picture here. You can make out this here, the vessel, the arrow pointing to the constriction of the vessels. In multiple vessel areas going to constriction in RCVS, and they reverse themselves by 12 weeks time. The brain MRI can reveal infarcts, hemorrhages, and cortical circle subrectal hemorrhage. Apart from these three common conditions which can cause headache, there are also other causes of headache in pregnancy which are less common. Some brain tumors can grow rapidly during pregnancy, including meningiomas, choriocarcinomas, and PTT tumors. AV malformations have been found more commonly during pregnancy and tend to bleed in the middle or towards the end of the pregnancy. Aneurysms are more likely to bleed during the weeks 30 to 40. Sometimes the headache you investigated, you found no cause, it may be primary headache. Approximately 60 to 70% migraines improve during pregnancy, usually in the third and fourth month. Headache often return in the first postpartum period. So if migraine patient is coming to you, want to become pregnant, you can safely stop the anti-migraine medication. It's a proper medication. You can assure them most of the time it will subside during pregnancy, but can occur during the postpartum period. However, the first migraine attack rarely may occur for the first time during the pregnancy, especially the first trimester. And another entity is the postpartum headache, which is seen in 34% of women, typically from day 3 to 6. Usually less severe than the migraine headache, usually bifrontal, prolonged, associated with photophobia, nausea, and anorexia. It mimics migraine headache. How to treat migraine during pregnancy? Paracetamol does not cause, sorry, it does not does cause placenta, but there is no increase in the birth defect has been attributed to its use. That's a drug of choice when you want to give during pregnancy. The non-steroidal anti-inflammatory drugs like ibuprofen or naproxen are generally safe during the first 2 trimesters, but carry the risk of premature caution of patent ductus arteriosus, decrease the amniotic fluid volume, and increase labor and bleeding, inhibition of labor and bleeding during the 3rd trimester should be avoided during the 3rd trimester. Metoclopramide can be given safely during pregnancy, which can be given as an acute migraine treatment. If you want a prophylaxis for migraine, recurrent migraine during pregnancy, you can give beta blockers at low dosage. There is no tetragenicity with propranolol. Similarly, amitriptyline can be given safely at low dosage. Coming to the 3rd scenario is acute neurological disease like a stroke in the pregnancy. Pregnancy and puerperium confer an increased risk of ischemic as well as hemorrhagic stroke, with incidence rates being 3-fold higher compared to the non-pregnant women. The daily rate of stroke is higher in the postpartum period compared to the pre- and peripartum periods. And that too in the first 6 weeks. Now, what causes stroke during the pregnancy? Most common cause of ischemic stroke are cardioembolism, coagulopathy, and preeclampsia and eclampsia. The most common cause of hemorrhagic strokes are the aneurysmal bleed, AVM bleed, and of course other which are peculiar to the pregnancy like preeclampsia, HELP syndrome, and coagulopathy. The risk factors of stroke, as Cheif was telling, the most common is hypertension, then followed by migraine, thrombophilia, SLE, heart disease, sickle cell anemia, thrombocytopenia. But the most common is hypertension. Other rare causes include postpartum infections, peripartum cardiomyopathy, choriocarcinoma, amniotic fluid embolism. The risk of peripartum stroke and venous thrombosis is more for women who had a cesarean birth compared to those with vaginal delivery. Now, this is the one which ought to be remember about it, hypertensive disorders during pregnancy. These are a group of conditions occurring in pregnancy and puerperium with a common background of hypertension, defined as BP greater than or equal to 140/90. Included in this group are gestational hypertension, preeclampsia, severe preeclampsia, chronic hypertension with superimposed preeclampsia. It's a strong risk factor for cardiovascular disease and stroke during the pregnancy and puerperium and later in life. These women has 1.8 times the cumulative risk of stroke in the years following childbirth. And preeclampsia is associated with 4-fold increase in the future incidence of heart failure and 2-fold increased risk of coronary artery disease, stroke, and death. HTP is associated with both ischemic and hemorrhagic stroke, and also other conditions which have already been mentioned like PRES and RCVS. What are the factors contributing to the increased risk? There can be hemodynamic changes, there are very many, I will not go to that. There can be changes in the vascular and connective tissue changes and changes in the coagulation system. They predispose to the increased risk of stroke during pregnancy. How do you treat? It's controversial. You give RTP and acute stroke, but whether to give during pregnancy is controversial because the chance of bleeding which can occur in the placenta. So these guidelines now states that for the Canadian statement that it is reasonable to consider IV etoplase to a pregnant woman who otherwise meets the thrombolysis criteria and has a disabling ischemic stroke, but this should be performed with the guidance of an interdisciplinary team. Etoplase does not cause placenta and it's not expected to increase the risk of intracranial or systemic bleeding in the fetus. So the decision to administer the drug is based on maternal bleeding risk associated with acute stroke. Then how to prevent secondary stroke? The aspirin by far the most widely used antithrombotic drug it is deemed safe for use in the second and third trimester trimesters for fetus and the mother. In the first trimester, however, aspirin use has been reported to have an association with increased incidence of fetal gastroschisis and other fetal malformations. Can we use anticoagulation for cardioembolic stroke during pregnancy? Warfarin is contraindicated due to the teratogenic effect as well as the risk of fetal hemorrhages. It should be avoided in early pregnancy and if at all throughout the entire pregnancy because it may also cause CNS abnormalities in the second and third trimesters. And preference is for heparin, that is unfractionated heparin or low molecular heparin, both can be given, but unfractionated heparin can increase the risk of maternal thrombocytopenia and osteoporosis. One should not use novel anticoagulations during pregnancy because of the uncertain safety provided. I think I will not go to the neuropathies. Remember that many neuropathies can occur in the postpartum due to the compression of the nerves, which are almost of them benign. They improve by themselves by about 4 to 6 weeks time. So I think I will stop here. Thank you for your patient listening.
Thank you, sir, for that wonderful lecture. There are a lot of questions. We'll take up the questions at the end of after the madam's talk.
Okay, sure.
Because say there will be a lot of questions which will be which may be mixed up together. So we'll take up the questions at the end of the total discussion. And now invite Professor Sreedevi madam to make her presentation. Over to you, ma'am.
Hello.
Yeah.
Hello.
You're audible, madam.
Okay. Thank you. Can you see my screen?
Yeah, we can. We can see, ma'am. Madam, unmute.
Hello.
Yeah, audible.
Yeah. Okay. Good evening to you all, Sir Sekharan, Sir Madhu, Sir Kunjumaideen, and the whole team, Perinalmana team.
Unmute. Madam, mute ആയിട്ടുണ്ട്. Sreedevi madam mute ആണ്.
Yes.
Yeah.
Yes.
Okay.
So now coming to the topic, neurological disorders complicating pregnancy, obstetricians dilemmas. Most of the topics have been already introduced, and whatever the neurologist has to highlight, Professor Madhusoodanan has highlighted. I have only a little job to do in this scenario. Mole. Your slide movie, Mole. Hello. Mole. Slide movie. Yes. Yeah. So, hello.
Yeah.
Hello.
Yes, we can hear, madam. We can hear.
Okay. In between, the slide was not moving. Sorry for that. So the problems during pregnancy in these neurological problems, it may be the pregnancy related ones, or an exacerbation of a pre-existing neurological problem, or a systemic disease detected for the first time during pregnancy. That these are the types of situations we may come across. In any situation, neurological problem, preconception counseling is important in a woman who has got problems or a family history of problems. What is meant by preconception counseling? The latest definition is a set of interventions that aim to identify and modify the biomedical, behavioral, and social risks to a woman's health or pregnancy outcome through prevention and management. So the general considerations, all women of childbearing potential should receive folic acid 0.4 milligram per day. That is for a normal pregnant woman. Normal woman without any previous disease, 0.4 milligram. History of previous neural tube defects. There should be a consultation with a geneticist and a targeted filter ultrasound should be done. And the dose of folic acid has to be increased to 4 milligram per day in a case, especially with a history of neural tube defect. And she should be advised to avoid alcohol, smoking, and illegal drugs, especially cocaine. And very important point is, in our state, there is a very high risk of diabetes before pregnancy and detected during pregnancy. So the control of diabetes and over diabetes is very important. And they should have a normal blood sugar level when she conceives. Women with neurological disease planning pregnancy, preconceptional counseling, especially by an obstetrician, in consultation with a neurologist or a geneticist if there is a high risk. And all the teratogenic drugs should be discontinued. This scenario I have put only very few because whatever has to be mentioned and detailed by a neurologist has been already done by Dr. Madhusoodanan. So this is a scenario where a 32-year-old primi gravida was referred. This is a real scenario we came across. 36 weeks of gestation with headache, nausea, vomiting, and she came to the casualty when the recorded BP was 150 by 120 millimeters of mercury. So the first possibility we think of is a case of severe preeclampsia because the diastolic is already 120 and the woman is having symptoms. Features of severe preeclampsia, as you all know, the BP of 160 systolic by 110 diastolic equal to or more than that. And it is usually associated with other blood abnormalities like thrombocytopenia less than 1 lakh, impaired liver enzymes twice normal values, liver enzymes are elevated, and the woman may complain of right upper quadrant pain or epigastric pain, and unresponsive to medication sometimes, progressive renal insufficiency, and the serum creatinine may be raised to 1.1 or a doubling of creatinine in the absence of renal disease. That is important. And she may have developed pulmonary edema. Even while on treatment, she may go in for a pulmonary edema and new onset cerebral or visual disturbances. This patient is having symptoms. She has got high BP and it is a case of impending eclampsia or a severe preeclampsia. The other term you can use is severe preeclampsia. So the aim should be, in a case of impending eclampsia, she has come to you. The first thing you have to prevent is eclampsia, because once she throws fit, definitely the complications are more and there is a higher chance for complications and sometimes even maternal death, which has been considerably reduced by the very prompt management and advices by the Kerala Federation. All of us are following the KFO guidelines. The bolus dose, first line drug to be given is magnesium sulfate, 4 gram IV, 20% solution, slowly over a period of 5 minutes. So in any casualty, this drug, magnesium sulfate and labetalol, should be stocked in the casualty itself. Once the woman comes to the casualty, this should be given, and then only the woman should be shifted to the labor room or the ICU. And 4 gram of magnesium sulfate in 100 ml of normal saline to be run as to be run IV intravenously. So bolus dose is given 4 gram 20% solution. The magnesium sulfate infusion to be started after that with 1 gram per hour for 24 hours. For that, we have the magnesium sulfate is in an ampule containing 1 gram 2 ml of solution. So you have to take 8 ampules, and this is taken in an infusion pump if available and given at a rate of 1 gram as already mentioned. The next line drug is antihypertensive, and the antihypertensive of choice we were giving nifedipine and other drugs. Now the drug of choice is labetalol, which is given as IV 20 milligrams. And At the end of this 20 milligram, 10 minutes of giving the drug, you have to check the BP. If it has not come down to the expected level, then you have to give 40. At the end of another 10 minutes, not control, come down to level of 140, 90 or so, give 80 milligram. And repeat another dose of 80 milligram. Up to that dose you can give. By that time, mostly the blood pressure would have come down to 145 to 150 systolic, 90 to 95. That is the target level. And monitoring, when you give these drugs, it is important to monitor the woman. You have the 3 important points to be noted are the knee jerk, the respiratory rate, the oxygen saturation, and the urine output. So to measure the urine output, once we have started these drugs, put an indwelling catheter and urine output hourly to be measured. And you should be we are alerted when the knee jerk becomes absent, or respiratory rate is less than 40, or SpO2 is less than 95%, or the urine output is less than 30 ml per hour. These are the parameters to be carefully monitored in treating such a woman with magnesium sulfate. So the blood investigations are, as you all know, the hemoglobin level, hematocrit, platelets, peripherasmia, liver function test, renal function test, LDH, urine routine, and the fundus examination. And all these parameters give an idea regarding the maternal condition. Now the fetus, what about the fetus? So there we have to go for an ultrasonography, assess the fetus, and the circulation combined with the Doppler is mandatory. Then only we can assess the fetal condition satisfactorily. Specific management in every case of hypertension complicating pregnancy is termination of pregnancy. And this depends upon the maternal and fetal parameters and the gestational age. Combined decision is taken based on these. The indications for termination of pregnancy are, all of you know, persistent symptoms of severe hypertension. Once she has thrown a fit, definitely it has to be terminated, whatever the period of gestation, whatever the condition of the fetus. She develops pulmonary edema. There is evidence of HELLP syndrome by the blood investigations, renal function derangement, coagulopathy, or a case of status eclampticus. Abruptio placenta, separation of placenta has already started because of the high BP, or a fetal compromise. Termination is the management. Our aim is to save the mother. Maternal mortality has to be prevented. So emergency cesarean may be indicated in many of these situations. Maybe the baby is premature, but we have to save the mother. So the precautions to be taken in a case of HELLP syndrome. Suppose she has gone in already for a HELLP syndrome. Platelet transfusion, arrange enough of platelets. Transfusion to be started just prior to cesarean section. In case the platelet count is less than 80,000, sometimes some people take it as 75,000. So at the start of surgery, at least you should start. FFP in case of coagulopathy, Paxil transfusion to be arranged. And once you have gone in for, when you have finished the cesarean section, while before closing the abdomen, definitely put an intraperitoneal drain, and a drain should be put under the ejector sheath because there is every chance for bleeding and blood collecting inside, which may endanger the mother. Postpartum thromboprophylaxis is important in these cases. Only regarding the management of severe preeclampsia. A woman, 31 years, second scenario, 26 weeks gestation, referred to a higher center with the diagnosis of multiple sclerosis. I am not a person to be highlighted on this disease, but multiple sclerosis, it is an immune-mediated inflammatory disease which destroys the myelin axons and the axons in variable degrees. We may be able to highlight the points from Dr. Madhusoodanan after this session. Another one is a second gravida, para 1, living 1, 38 weeks plus 4 days, epilepsy. I think many of the points have been already covered about the management of epilepsy during pregnancy, after pregnancy, and about the issues for the mother and the fetus. This patient, what happened was while after delivery, everything was fine during the antenatal period, and during delivery also the baby came out, baby cried immediately, and this is one which happened in our institution. While suturing episiotomy, she again threw a fit, an episode of seizure. Throughout pregnancy, she was free of convulsion, but this time it occurred during the suturing of episiotomy. So the points to be considered are, one is we have to manage the convulsion. Most probably, this is we consider it as an epileptic seizure because she is a known case of epilepsy. If she has got high BP, we have to designate it as a case of eclampsia. So this is a dire emergency. We have to prevent so many things like aspiration, falling from bed, all those things. The drug of choice during convulsion in this situation is benzodiazepine, phenytoin, or phenobarbital. One thing we have to make sure is, why this sort of woman, she is in labor and epileptic on drugs. Always we have to make sure that the patient has been given the daily dose of the drug. That is very important. Daily dose has been taken or not, and continue with routine medications after that. In epilepsy, preconceptional care is very important. Optimize the seizure management before pregnancy. EEG monitoring for classifying intractable seizures before conception. And we have to optimize the treatment to control the convulsion and also minimize the risk to the woman and fetus. Women who are free for at least 9 months before conception will likely to remain so during pregnancy also. Any opinion from Dr. Madhu? We will get it later. Anti-epileptics in pregnancy, the aims are seizure control, main priority. Seizure frequency usually due to subtherapeutic anticonvulsant serum levels. Sometimes even if we advise in consultation with a neurologist, we give a therapeutic dosage of drug, which will prevent also, but they may not continue the treatment properly as advised because they are afraid, afraid of the consequences to the fetus. So this, when we advise these drugs, we have to properly instruct the woman that she should take the drug properly, and it will not harm the fetus most often, as has been highlighted by Dr. Madhu. Then he has already given the idea that lamotrigine and levetiracetam are the ones which have lowest genital malformations. Valproate and carbamazepine, all this has been already mentioned. The pregnancy complications in case of epilepsy, they are spontaneous abortion, embryologic manifestations, maybe because of the drug or otherwise. Hemorrhage can occur. Hypertensive disorders are also common and leading on to preterm delivery, fetal growth restriction, increased cesarean rate. I'm not going to the details which has been already mentioned. Another scenario, third scenario, status epilepticus in a primigravida at 36 weeks. Status epilepticus, the convulsion which is lasting longer than 5 minutes, more than one seizure within 5 minutes period without returning to a normal level of consciousness between episodes. That is the idea of a status epilepticus. So here both the mother and the fetus at risk. Most common causes mentioned is posterior reversible encephalopathy syndrome or reversible cerebral vasoconstriction syndrome, spectra, cortical venous thrombosis, or an autoimmune encephalitis. The first line management depends upon the etiology and the duration of pregnancy. Good prognosis if detected early and treated appropriately. The drugs have been already mentioned. Specific recommendations in epilepsy, I don't have to highlight on this again, so I skip the slide. And lastly, one of the new information which I got was about COVID-19 and pregnancy, any neurological manifestation. Yes, one of the thing which has been mentioned is it could promote brain endothelial damage. Patient can develop tonic-clonic seizures. And at this point of time, the BP may previously a normal BP, the woman having a normal BP at this point of time, the BP will show a high recording. She may throw a fit, go in for, we may call it an eclampsia, more chance of cesarean section. Blood investigation shows an increased LDH and increase in the D-dimer. Pregnancy with multiple sclerosis, very, very rare situation we've come across. And in a case of multiple sclerosis, the problems which we come across are, one is abortions, increased rate of abortions. Relapse rates are very high. Fetal growth restriction, one of the very common or almost 90%. And the labor also, slow progression, and relapse more after delivery for 3 months. So these are some of the ideas which came into my mind, and I think we may be able to discuss it further in this platform. Thank you, Dr. Koinumedi, for having given me this opportunity. Thank you.
Thank you, madam, for that wonderful lecture. Sekharan sir, we will take up the questions. The questions are there in the chat box.
Okay, before going to the questions, both the speakers are presented in a very practical way, step by step, the situations and how to go about it. And thank you very much, Professor Madhusoodanan and Dr. Sreedevi, for that, helping us how to sort out the situation. Before going to the questions, see, one of the problems that I have seen or we are seeing is epilepsy somehow is taken as a social stigma, bad stigma, and the problem is the in-laws may be kept out of knowledge of this particular disease of that girl. The girl, if she becomes pregnant, she has to have real support during pregnancy, an epileptic woman. She has to have good sleep, rest, and there should not be any factor that will produce stress, which will precipitate a fit. So unfortunately, in this situation, the girl is in a very big dilemma. It is not told to even to her husband, and the in-laws doesn't know, and the timely taking the medicine is also may not be possible for her. So this poses problem, and I have seen practically many such girls. They have kept it as a secret. The first thing the mother, when they bring the patient, will be telling us, please don't tell that my daughter is having epilepsy to the in-laws. So this is the question, and we are in a dilemma. She needs very good support during pregnancy, labor, and puerperium, especially rest, sleep, and support. And this is lacking in many of such cases, which will create problem, and that will result in recurrent fits also, repeated fits. So that is one problem. Professor Madhusoodanan has told the hemodynamics in pregnancy that will necessitate the increase in dosage that is required for control of fits. And if at all you have to increase the dose after the delivery, at least after 10 days of delivery, you have to have a consultation with the neurologist and reduce the dose, because by that otherwise, especially lamotrigine and other things may produce a problem because of the higher dose. The best thing to do in an epileptic woman is to have a planned pregnancy. So any physician treating a woman, girl in the reproductive age, should be counseling them that you should plan your pregnancy so that at least 3 months of exposure to or administration of folic acid before becoming pregnancy and continued for at least 3 months after becoming pregnant is one of the way of preventing the toxicity of the valproic acid and other drugs. Professor Madhusoodanan also has told the increased risk of polytherapy. So try to control the fits with one drug alone and to the minimum effective dose. So that is other thing what Professor has told us. Now, so that is the comments I could make about other things. Then about the press and other thing, both of them have told us that it is a peculiar condition that is due to a vasogenic edema, due to some sort of toxic reaction to the thing and produces vasogenic edema. We were shown the MRI picture of all those things, and it has to be suspected, especially after delivery, after a cesarean section, especially after a spinal anesthesia. The patient may keep on telling about the headache, some difficulties. We may say it may be a spinal headache. We may keep on waiting, and then finally the patient may throw a fit because of the press. So it could be any headache after delivery, especially cesarean section, has to be carefully monitored because a sudden increase in the BP. Patient was only having mild BP before delivery. Afterwards, after delivery also the BP can go up. Even a mild elevation may tilt the trigger and she may go in for press and the fits and other complications. So any headache in the postpartum period, post-operative period has to be considered seriously. Other than the situation what Professor has told us is the venous thrombosis and other problems are also there. So it can be a stroke also. So in this critical period, we have to be extremely careful because even after delivery, the problem continues. Now to Professor Madhusoodanan, there is a question regarding what may be the safer drug for migraine.
Yeah. Am I audible to you? Yeah.
Yes, please.
Okay. If a person is a non-migraine patient, comes to you before become pregnant, should I continue prophylactic medication? That depends upon the severity and the frequency of the headache. The headache is a far and few in between, say once a month or 2 or 3 times a month. Ask them to avoid any prophylactic medication during pregnancy. At the most, you can take my paracetamol or Dol during the time of headache. That is good enough. On the other hand, the frequency of headache is frequency is so more that it warrants a prophylactic medication. The ideal preventive medicine will be propranolol and amitriptyline. These are the two good drugs which can be given, which will not produce a teratogenic side effect.
Thank you for that. Then there was a query regarding is pregnancy state increase the risk of a facial palsy?
No, it will not increase the risk of facial palsy. No.
Okay. Now, when a patient was on valproic acid, you said the pros and cons very well about the valproic acid and its problem. If at all somebody is to stop the drug before she became pregnant and she has come to in the pre-conception stage and she is asked to stop the valproic acid and go in for some other drug because she is so concerned about the effect on the baby. So
Correct.
after stopping the VPA, how many months may be the safe period to conceive?
Yeah.
I mean, she's on other drugs, of course, lesser toxic drug.
As far as sodium valproate is concerned, its half-life is low. So even you can wait even after 2 weeks is enough for the blood level to come down. So you can safely conceive after 2 to 3 weeks time.
Okay, so she has to be on folic acid and whatever other drugs are also better to give the folic acid if as for the growth.
That's a must, yeah.
Yeah, that is it. One question is or scenario is a patient who was pregnant had a road traffic accident, unconscious. She's on life support. She's 24 weeks. How long we can continue with the pregnancy to get? Can we carry on with the pregnancy with the life support in a sort of a brain dead patient?
That's a difficult question to answer for me because if it's a brain dead, then what's the meaning in continuing the life support?
Yeah.
That's
the pregnancy. Because of pregnancy, the relatives are so keen to have this baby. Baby's alive.
Okay.
And on life support, the baby is alive.
That can be continued, but invariably the brain is dead. The patient usually die, even if with all size life supports, they usually die over a period of 1 or 2 weeks time, even if full support.
Okay.
They will not remain like for a period of time.
Okay,
Unless it's a persistent vegetative state. Brain dead is relatively different from persistent vegetative state, where the brain stem function is retained, but all other cortical functions are lost. That patients can remain for long years and years on ventilator. If they want, they can continue like that, but not brain dead.
Okay, better not to think of other things.
Yeah.
Okay. In practice, we are having situations when the patient throws a fit, a eclamptic fit, and she is going on to coma. And on CT or MRI, we find a big cerebral hemorrhage or hematoma there. She is, say, 36 weeks. Do you advise her to do to have a cesarean done on her, or because of the brain is?
Absolutely.
Definitely.
Yeah, we'll go for cesarean. Whatever is the condition of the mother may improve, she may die. But when the baby is salvageable, even if the patient is in comatose state or coma because of the massive cerebral hemorrhage, try to get the baby. Okay, thank you. We can go ahead with that, isn't it?
I think we have to take the baby out as early as possible.
Yeah, because that's it. So there is no hesitation should be there actually. Then I should say lamotrigine, you said as the least toxic effect is with the lamotrigine, isn't it? So
Levetiracetam.
yeah, that is it, because maximum is with
Which one is cheaper, Madhu sir? Which one is cheaper?
Cheaper is lamotrigine is cheaper.
Okay, sir.
so that is safer also, least toxicity and cheaper also. What about the control of fits with this particular drug?
That's the thing I was about to tell you, that the choice of the drug depends upon the type of seizure. So there are instances where we have to continue sodium valproate, knowing well the side effects of sodium valproate even during pregnancy. For example, there is one type of epilepsy called juvenile myoclonic epilepsy. It's a very, very common epilepsy. For that, the ideal drug is sodium valproate. So if the child person comes to you already pregnant and on sodium valproate, I will continue the same dosage. I will not change anything. Ask them to accept the risk. The risks are maximum will be about 10%. You have to accept that. On the other hand, that girl comes to you before becoming pregnant and sodium valproate, I may change to another drug which is suitable for the particular seizure disorder, seizure type. For that thing, only two drugs are effective. One is alternative will be levetiracetam and lamotrigine. But mind you, these two drugs are much less efficacious compared to sodium valproate. So you may switch to the other drugs. Patient may throw seizure again. Again, you increase the dose of levetiracetam and lamotrigine. Ultimately, you land up in a situation where you have to necessarily give sodium valproate to control the seizure. So, set situations you can give sodium valproate and become pregnant. There's no, it's all. I mean, according to the European Medical Council, this thing a recommendation, you should not give sodium valproate. But that's not practicable in many situations. You can say that, but practically we may have to resort to even sodium valproate pregnancy. The seizures are not getting controlled with other medications.
Okay. There was another query was you said about the other. So patient in pregnancy beyond 20 weeks, during pregnancy, if the dictum is that the patient comes in develop fits beyond 20 weeks of pregnancy, take it as eclampsia and you start magnesium sulfate. That is everybody's advice. Will this magnesium sulfate have any effect, or if it is not eclampsia but other types of fits?
No. As far as seizure control is concerned, magnesium sulfate is not a good drug for other types of seizure disorder. Curiously, for eclampsia, this is the ideal drug. It is much, much better drug compared to any other anti-epileptic drugs. But we resort to magnesium sulfate very, very rarely when all other drugs fail. But I don't think that that's a good option at all.
Okay. So we are taking it as, because eclampsia is a diagnosis not with a specific pathological feature, that is almost a clinical diagnosis, and we take it. And in cases where the patient is not improving or going in coma for a longer time, you have to think of other causes as the we have to go in for such causes.
Yeah, perfectly well. That depends upon, suppose this child patient had been having seizure before. Obviously, that particular seizure is not due to eclampsia. You have to treat it with other anticonvulsants. For the first time developing a seizure during with other features of eclampsia, then only we can give to high magnesium.
Naturally, the phenytoin is also useful and effective in eclampsia, but the trials have proved that magnesium sulfate. We were giving phenytoin also, IV phenytoin also, but we were afraid of the cardiac effect of a higher dose, like 500,000 milligrams, like that IV. That was the regime what we were giving earlier than the approved use of the magnesium sulfate, or the trial has come out after 1995. Before that, we have tried all sorts of things, and we were giving phenytoin also, IV phenytoin also. What we found was sometimes the ECG abnormalities, and we are afraid of the cardiac arrest, something like that. But we were to manage all those things, and these were controlled, very well controlled. We could have the control of eclampsia also with the phenytoin also. It was a good drug. So in case of status, as Professor Sreedevi was mentioning, which is not controlled with our magnesium sulfate, what is your advice for us to give lorazepam or what?
Yeah, status epilepticus is a neurological emergency.
Yeah.
There is no, we have to, it's not look to the right and left. You have to manage aggressively. That means you start with the lorazepam, not controlled, again repeat lorazepam, and then go for either IV medications, either IV phenytoin loading. We can give levetiracetam, we can give lacosamide, and if at all, then go for midazolam drip. And that we have to escalate one by one.
Okay.
Till the seizures are getting controlled.
So we had a patient with a status. She was a eclampsia patient only. Status she developed. What we thought was at that time, what we did was we are given that inducing agent, what is phenobarbital IV was given. I mean what we induced for general. Yeah.
Pethidine, sir.
Not pethidine.
Oh.
Pentobarbital, you mean?
What is that?
Pentobarbital, you mean?
Yeah, it was given and induced, and we did a cesarean and continued with the magnesium sulfate. So situations are there. Even magnesium sulfate may not be acting in some cases. There we have to resort to other drugs.
Absolutely.
And phenytoin, now we have got the fosphenytoin. What is it? Fosphenytoin, which is the local reaction may not be there. It is available and can be used. That is what we have given in one patient who had developed stress and developed fits. Typical findings as you shown in the MRI. One patient with the post-operative case, she had a day, little bit, physician has seen, the anesthetist has seen some analgesics, but she was not improving, and suddenly she thrown a fit, and it was typically that press on the MRI picture. She does press. So that is what I said. Sometimes it may be a slight rise in the BP that may tilt the balance and you get the edema there. It may not be very high BP. From the normal, it is. So what we call the vasoregulatory mechanism may fail, and it may cause suddenly that edema and the fits may come. So any other question, Kunjumaidan? These are all what I could get. Anything else?
For anticonvulsant dosage, what we give, that magnesium sulfate and antihypertensives, even after giving all these training programs in the peripheries, they are using a lower dose. They are using a lower dose, and we got one patient referred with repeated convulsions and cerebral bleed, and patient succumbed to death. So that is happening even now.
So that is sad. Okay, we have to have the proper dosing, because
proper dosage is
prevention
important.
of recurrent fit is more. The first episode she may escape, but the recurrent fit she may go in for cerebral hemorrhage. Dr. Madhusoodanan, we have analyzed over a 10 years period, we had 110 eclampsia deaths, eclampsia deaths. 30, I think 42% were due to cerebral hemorrhage due to uncontrolled high blood pressure. So that is why even before giving magnesium sulfate, my request is always to give a levetrilol, bring down the BP. Even before starting the magnesium sulfate in case of eclampsia, bring down the BP if the BP is high. And that may be the only thing which may save the patient, because cerebral hemorrhage, vasoregulatory mechanism is failed, which is sudden. In eclampsia, what is happening is, from a rather slightly higher level, it goes suddenly to 170, 120 diastolic. That is where the fits occur because of the leak first, which may result in massive bleed. And we have seen on CT-MRI, many cases who is remaining comatose are due to massive hemorrhage. So we lost 44 women due to cerebral hemorrhage only. That is where I am stressing that we have to bring down the BP suddenly, even in eclampsia. I think is to give a shot of levetrilol 20 milligram IV, and then you dilute and give your magnesium sulfate. So bring down the BP is the first thing. We have seen because of the cerebral hemorrhage, 44 women typically due to hemorrhage only. The massive hemorrhage, and they succumb. So bringing down the BP is important. Controlling the fits is important. Whenever the fits are not controlled, look for other causes for the fits. It can be other organ, including a tumor, as you said. It can be a tumor also. So investigate. Don't think, close your eyes when the patient is not responding. It may be other causes, and get the help of our colleagues like neurologists, at least physicians, and look for any cause. It can be any space occupying lesion or a stroke. So we have to find out and try to save the patient. I think that's all what we could see in the chat.
There are some more questions like how frequently we should perform EEG in pregnancy with seizure disorders?
So, yeah, EEG is not required at all for any seizure disorder. In fact, the role of EEG is only one, to find out the type of epilepsy before starting the treatment. So once the patient is on anti-epileptic drug and control, there's no point in taking EEG at all. The EEG role will come when the patient has thrown a seizure. Seizure has subsided, but patient does not recover consciousness. Continue to remain unconscious. That means the patient may be having a non-convulsive status. The convulsion may not be seen, but may be convulsing in the brain. That's a situation where you need an EEG, repeated EEG, to find out whether the patient is having a non-convulsive status. Otherwise, there's no indication for taking any EEG for seizure disorder.
Okay, then what is the chance of seizure disorders to a baby born to an epileptic mother?
Yeah, that chance depends upon the type of epilepsy the mother is having. See, some of the epilepsies are genetic epilepsies, but unfortunately they are very rare. 2 to 3% only are genetic epilepsy. One such thing is juvenile myoclonic epilepsy. So, and that type can recur in the children. Otherwise, in 95% of the time, there is no increased risk in the children, except for the genetic epilepsies.
And Sreedevi, madam, what will be the safest mode of anesthesia for cesarean in a woman on treatment for epilepsy? Anesthesia for cesarean.
Anesthesia for cesarean section. Many times anesthetists, they prefer general anesthesia. General anesthesia. Any comments, Jayden sir?
For eclampsia and pre-eclampsia, it is better to give regional, even for eclampsia, because
this is about
when you intubate, a sudden increase in the BP can occur during intubation. That may also throw a fit or hemorrhage and other things. That's why in pre-eclampsia, whether it is severe or even in eclampsia, after the settlement of the eclampsia only, we will try to do anything. After stabilizing the patient, the anesthesia preferred is regional anesthesia in hypertensive disorders rather than general, because a sudden shooting of the BP can occur. Epilepsy, they will prefer general anesthesia.
General anesthesia. And in cases of severe preeclampsia with
Madhusoodanan, sir? What is your comment, sir?
Yeah, same. What you said is exactly correct. Yeah, better to go for a regional anesthesia.
In cases of severe preeclampsia with low platelet thrombocytopenia, they prefer general.
Correct.
Epidural for labor analgesia.
Sure. That is recommended even for epileptic patient who is delivering.
Yeah.
Proper analgesia and epidural is recommended there also. There should be in a properly protected cot. The delivery cot should be side railings and properly protected, and always anticipate she may throw a fit. Give the due medication in labor also. Don't cut anything. They have to have. Hydrate the patient during labor in an epileptic patient who is delivering. Hydrate well, if necessary by IV fluid. Support her. Her relatives can be standing with her and support her, give support. Avoid the stress as far as possible, because these are trigger for the fits. And if they throw a fit during labor, we had it. It is very dangerous. So she may fall from the cot and injure herself, and it is a very serious thing. So keep the bystanders. I will recommend 2 of them. When the epileptic woman is delivering, keep the bystander with the side of the patient, and they should be seeing what we are struggling, and they should be supporting us also to help the woman, and we are to give necessary support. And sedation and analgesia is very important during labor in an epileptic patient. She will not tolerate any pain, and she will be anxious that will precipitate a fit. So it is very important to give the support, give the sedation or analgesia, regional anesthesia, and also support from her relatives, hydration, and taking care. If at all she throw a fit, she should not fall and get injured by herself. So all those things are important during labor.
The questions are almost over. And the one more question that is almost the same. Any special instructions or continuation of anti-epileptic drug for a lady planning to go for IVF? So it is same thing like preparing for pregnancy, isn't it?
Yes,
Preconception.
it is right.
So anybody else want to add anything? Any concluding remarks from each one of you, ma'am, sir?
No.
Okay, it was well
Yes,
presented by
thank you.
both.
Thank you very much for inviting me to be part of this interesting program. I also learned a lot from Dr. Sekharan and Dr. Sreedevi. Thank you. Thank you all.
Yeah,
We
actually,
had a very revision of neurology from you. That is
good
very
discussion.
good.
Yeah, definitely, sir.
So I invite Dr. Abdul Wahab for the official vote of thanks. Dr. Wahab. Wahab.
His video is off.
Yeah. I think he is in the theater rope. I don't know.
Okay.
Anyway, on behalf Wahab, please tell vote of thanks. Wahab, unmute. He might be in between seeing the patients while after logging in. There is a possibility. Anyway, on behalf of all the members of POGS and the entire team of office bearers of POGS, Wahab, please.
Yes, Wahab.
So sorry, sir. Actually, it was
It's okay. Welcome. Welcome to say we want to. That's right.
thanks for my teacher and professor, and once sir was my professor also, professor and HOD as a colleague in my MES Medical College, and again thanks to Professor Sreedevi madam, and also the Crosstalk, which become actually so live because of the Madhu sir, the neurologist perspective, and thanks to all who attend this program and made a big success. And this is our venture of Crosstalk, which meant all other specialty also as some included in our day-to-day practice. And thanks to all of you, and especially our leader and very active President Kunjumuddin. Thanks to all.
Thank you.
Thank you so much. Thank you, Sekharan sir.
Thank you.
Madhu sir.
Thank you all. Thank you, Madhu sir, Sekharan sir.
Enjoy.
Thank you.
Thank
See
you.
you. Thanks a lot.